referral hospital, and the Ministry of Health in Kenya, and then now a consortium of 11 other institutions in North America who are universities and academic health centers. So in Eldoret, we have a housing compound or hostel, and really since the 1990s, every week we've had these fireside chats where we gather together in one of the houses or sometimes outside next to a fire, and sort of create an opportunity to learn and reflect as a group on some of the experiences that we've had in the wards and in a different culture. So tonight we're privileged to have with us Palka Patel and Jenny Benzinger, two of our former AMPATH trainees who are now fully grown AMPATH Global Health faculty and experts and teachers, and we're very lucky to have them. I'm not going to describe so much of our exchange program because I think I'll let them sort of just go through their presentation first, and then we can sort of come back to what AMPATH's model is like and sort of evaluate in the context of what they're talking about. Just to give a brief update on what's happening in Kenya. So as the COVID pandemic continues, obviously our commitment to the AMPATH partnership remains as strong as ever. There's no more clear example of the importance of global health than a global pandemic. I think that's the message we need to keep bringing home here as we think about travel bans and everything else. So as Deb said, please keep yourselves on mute, but you're welcome to ask questions through the chat, or if we get a chance to open it up, then unmute yourselves. So we're going to start with Dr. Palka Patel, and then I think she'll turn it over to Jenny. Introduce yourselves.
Great, and I think I'm already unmuted, that's right. Can you guys all hear me?
We can hear you.
Perfect. Well, thank you. And once Jenny starts sharing the slides, I'm Palka Patel, and I'm currently a hospitalist at Eskenazi Hospital, our county hospital here in Indianapolis. I am also affiliated with the IU School of Medicine. I completed my medical school and residency here at IU along with Jenny. So we were in medical school together and in the same residency class. But after residency and before my current role, I spent about 3.5 years working internationally. So I spent 1 year working in Angola for Baylor College of Medicine's international pediatric program, and about 2.5 years in Mbarara, Uganda, working as the site director for Massachusetts General Hospital's international partnership at that location. And that's actually where I met former team leader, Dr. Karen Stone, and current medicine team leader, Dr. Katrin Kelly. So I've also traveled, as Adrian mentioned, to the AMPATH site in Eldoret, once as a medical student, again as a resident, and now as faculty. So I definitely appreciate the opportunity to share some thoughts and stories with everyone today. And I'm definitely excited to present with my really good friend, Jenny.
Thank you. I'm Jenny Benziger. This is a picture of Palka and I graduating from residency together. So I also went to IU School of Medicine and stayed for IU Med Peds residency. Now I'm faculty at Eskenazi Health as a hospitalist and on a clinic on the east side. In another part of my job, I'm the Assistant Director of Education for the Center of Global Health and get to direct global health activities for medical students and residents, including leading our global health track. So today we are going to work on understanding the who, what, when, where, and why of short-term global health trips. We're going to consider how short-term trips fall into the larger context of global health and the history of colonialism. We're going to identify some concerns with short-term trips and then learn what might be helpful and supportive. We really wanted to start with a big caveat that we are not interested in shaming anyone about previous trips. I have spent time in Honduras, India, Kenya, and there are things that worked great about all of those and things that didn't. So I hope nobody ever feels like we are saying you didn't do it right, or at least that you should feel shame about it. So we do want you to think carefully about how, when, and why you go on trips. Consider what you do and how you act while you're there. And also just a huge disclaimer, we're US trained and based faculty. We're very limited in our perspective by the nature of being human. So we invite your input and we need it, and we're going to invite it as we go on. So be prepared to contribute. So first, I wanted to start out with an example. And this may be just sort of set the stage for what kind of trips we're talking about in the rest of this talk. So this is Kate. She is your classic third-year medical student. Kate is excited about doing a global health elective. She has an idea planned out. She's going to go to a rural mission hospital in Central America. She is has planned to do a project there about hand washing and has made a plan with her US faculty. She hasn't talked to any faculty at the local place. She's really excited about it. It's going to be a 1-week trip in between her 3rd and 4th year. So, however, she sits down with some friends as she's planning this trip and getting really excited to go. And she is very surprised to figure out that not everybody is quite as excited about it as she is. They say things like, well, aren't there people who need your help here in the States? Why do you have to go overseas? Another resident says, I've heard that the place you're going has actually no supervision and maybe you'll see some cool stuff, but you're not going to get any help for the whole month you're there. Another person says, are you just doing this for yourself or you really want to help people? Is this just for your residency application? So she's starting to actually feel worse about herself than when she actually came. And she's wondering how to sort out how to know if this is a good or bad opportunity. So keep this medical student in mind as we go through, and we'll talk more about her at the end. So let's take a minute to just talk about the what, where, and why. So I realize that conversations with this many people can be quite challenging, but can you guys unmute yourself for a second and help us think about who goes on these? I'll ask you the question in a second. Who goes on these trips? Where do they go and why do they go? And then in a minute, we're going to be asking who benefits. So we have those 2 questions percolating in your mind. And I'll just put out the kind of disclaimer or caveat before we answer those questions that people call these trips lots of different things. So you may have heard them called medical missions, which had its roots perhaps in a spiritual or faith-based context, but can mean a wide variety of organizations that send folks now. You may call them things like global health electives, if it's particularly in an academic context. You may just hear them be called global health trips without any more adjectives. Or if you start to hear some of the judgments, it may be things like voluntourism, etc. So most of the trips that we're talking about are anywhere between 1 week and a few weeks. Almost the large majority are 1 week in duration or 2. And they can be to any place around the world. Traditionally, well, at least classically, they're in places that are easy to travel to and that are open to visitors. So, however, that has changed, of course, over time. So as we think about this, I'd like you guys' input on this next question. Who benefits from these trips? And I think there's lots of people that benefit. So I'd like to have either in the chat or just unmute yourself, who benefits from trips like this? Danielle says the travelers, definitely. So the students or the short-term people, absolutely. Who else? After all, this is a fireside chat, so we have to chat about something. The communities you are serving. I think absolutely, yeah. There are many examples where communities really do benefit from the people who are served. I mean, so I think that's a great example.
The individual patients that are served?
Individual patients, absolutely. And that's one thing I tell my learners all the time. Like, even if you can't make systems change, you can influence the life of one patient. If done correctly, the medical staff, also perfect. The communities they visit. Michael says, sometimes the communities, but only sometimes. Oh, I love Charles's answer. The school from which you are traveling for recruitment and funding. Excellent. The airlines certainly benefit. I'm sure they've been feeling it in the COVID era where people aren't traveling. The traveler. Good. Good. I think that's a good list. And I think I expect and hope that this is a sympathetic audience to the fact that there are lots of people on that list other than the communities at stake, which is not bad, right? Like we want our students and communities and schools to benefit. That's part of how we keep the world working, is for everybody to have benefit. So it's good to realize though who's getting those benefits. Sonek says the more important question to me is who is it designed to benefit? Absolutely, or at least who gets the credit for the benefit. Okay. Next is going to talk to us about the background and the context of these trips.
Great. Thanks, Jenny. So for Kate, other students, trainees, and faculties traveling for long or short trips to help, it's important to understand the background and the larger context of your destination. Next slide, please. While there are many locations where short-term global health activities are conducted, I want to use a couple African examples as case studies or examples to think about context and background. So, sorry, can you go back one slide, I think? In the late 1800s and early 1900s, Africa was colonized by European countries and individuals. So the cartoon on the left depicts the 1884 Berlin Conference or Congo Conference, where parts of Africa were carved up like that cake that's being depicted. There was no consideration for existing local rural or ethnic groups. No African leaders were present at that conference, and that imperialism overrode most of existing African autonomy and self-governance. So on the right, this map shows most of the colonial powers that existed in different parts of Africa. Yeah, the next slide, please. The man on the left is King Leopold II, who took over Congo, most of what we consider the DRC today. So under his rule and reign of terror, it's estimated that between 1 and 15 million Congolese people died. King Leopold made money from rubber, and while waiting for plantations to grow, the desire for more rubber led to using and abusing local people to collect rubber from the surrounding jungle. So armed men would go to villages, kidnap women and children, and demand that men bring back rubber. When individuals or groups didn't meet the high quotas expected of them, the hands or feet of individuals or their family members would be chopped off, or their families would be killed. The photo on the right is of a man looking down at the severed hand and foot of his 5-year-old daughter. The atrocities committed were beyond imaginable, and I definitely recommend that if you're interested to read more about what happened in Congo. Next slide, please. So many of the countries that have been colonized in the past is, that's where we're going for a lot of these global health trips. They're what we would consider resource poor. However, the reality for Africa is the continent is actually very rich in natural resources. The map on the left shows some of those resources, and the depictions on the right reflect the extraction of those resources by colonizers or the global north, as you sometimes hear Westerners called, for their own use. In this way, the global north profits from the poor. Once resources are extracted, interested foreign parties leave, and no resources are left for local people. Next slide, please. So after residency, I spent a year working in Angola, and I'd like to use that as an example. So Angola actually has an exclave province called Cabinda, which is in the northwest of the country, highlighted by that red arrow. So it's actually not attached to the rest of the country, and that's where I was located, in that weird province. And the reason that Angola holds on to that piece of land is because it's specifically rich in oil, both offshore and onshore. So the beach on the right is one of the beaches in Cabinda. And while it's beautiful, if you go there at night and look out over the water, you can see about 16 fires from the offshore drilling platforms that are burning off the natural gas. So what you were seeing there was the resources being sucked out of the ground for the benefit of those corporations to make people rich. And the oil that comes from Angola does bring in money to those who are connected to that industry. If you look at the top left photo, that's the capital, Luanda, and you can see high-rise buildings, expensive cars. And Africa's richest woman, Isabel dos Santos, is from Angola. She's the daughter of the former president. Next slide, please. Despite those natural resources and riches, the majority of the Angolan population suffers. So the wealth becomes concentrated in the hands of few, and the companies that source the resources from there, as long with these few rich people in the country, have a vested interest to keep the wealth and power, keep the oil flows going, and maintain the status quo that they have. They want to look the other way with respect to health, wealth, and development of the rest of the population. Next slide, please. As we move on from the context and background, global health in turn seeks to help people in places like Angola. So if you guys would like to put in the chat or unmute yourselves, are there any costs or harm to these trips where we try to help people? What should our medical student Kate think of as potential harms? So while you guys are thinking or typing, I think, you know, the things that I think of are actual monetary costs. So like paying for a flight, sustainability, okay. So is the practice sustainable to the economy, or does it put stress on the economy? Think about stress and burden placed on individuals like host country clinicians who may now need to be your interpreter. Yes, you're right, Michael, that there are sometimes unreasonable expectations being created by these trips. Is it something that local people could be doing themselves? Do we really have to go? So destabilization of local infrastructure, use of scarce resources, love it. Establishing dependence. Sure, absolutely, I love it. Yes, so I think another big point is that white savior mentality. So a downside to global health is that it perpetuates that white or Western savior mentality, and rich and knowledgeable saviors from the global north try to charitably go and help uneducated and impoverished inhabitants of lower middle income countries. Perpetuating colonialism, perfect, love it. Next slide, please. I think I may have missed some of the chats, but I think some less evident costs are depicted here. So when I showed this chest x-ray from Africa for a morning report case in the United States, was that not also stealing? I mean, though I took that de-identified image with permission, I didn't share it or the educational case or discussion with my local colleagues in Uganda. In effect, I extracted patient information to create a Western educational opportunity that local Ugandans didn't get to experience to the same degree. Another area of inequity is in global health research. Just looking at authorship of work done in Africa published over 2 years, of those countries with North-South collaboration, so high-income, low-income collaborations, 13% of studies in this paper had no local authors, none. A little over half of the papers had local first authors, and when the US, Canada, or Europe were involved, that representation drops to under half at around 41%. Again, work done in these settings, this type of research can be extractive. It takes data from populations, uses it to advance academic and personal progress of researchers from the global north, and sometimes has little input from those researchers in the global south. There's a longer and larger conversation to be had at another time to consider other implications and issues related to global health, research surrounding ethics, implementation, and exploitativeness. And then global health can be big business. NGOs, health organizations that aim to help the poor sometimes can do more harm. They divert funding to themselves, of course, to pay their staff, overhead, admin grants, and projects. But sometimes the people who are trying to help only see pennies on the dollar of what's being invested to help them. Next slide, please. So that's a lot, and this is a lot too. With respect to taking a short-term medical trip, I do think it's important to at least learn or hear about the recent movement to decolonize global health. Thinking about global health in general, it stems from tropical medicine, which developed in order to treat colonial settlers who contracted those tropical diseases. By keeping them and the populations they worked with healthy, tropical medicine practitioners contributed to the productivity of the colony and the wealth of the colonizer. Although today's global health says we're for equity and health for all, we still have a top-down approach from a high income to a low and middle income country. We value the priorities important to those people at the top. And the people at the top are from wealthy, white, global North partners, often men, and global South faces and organizations can be few. They can be limited in their power or decision-making capacity within their organizations. So we've already discussed some of the problems with global health research and its extractive nature. That also perpetuates and adds to the colonialism of global health. So for our student and anyone planning to do a short-term global health elective, I'd recommend that you examine the colonial influences and the history, not only in the country where you plan to travel to, but also in the group that you're working with. Can you see local advocates with a real seat at the table, a real decision-making role? If not, can you advocate for power and equity for your colleagues in the country you're going to? And how does your relative power and privilege affect your work and your learning? Can you actually spend your privilege? Can you change or call attention to a way that global health can be more equitable? Next slide, please. So I think, here we're gonna move on to things that Kate, our medical student, can do when she travels. And we'll spend a little bit of time thinking about having her consider her words, her actions, and her motivations while traveling and doing global health work. So I think for those who may have joined late, I spent a year in Angola, and then I spent 2.5 years working in Uganda. And so a lot of the pictures and stories are from those times. So the pictures I've shared below represent two different views of students from the same hospital. On the left is an article published in the late 90s about Mbarara Hospital, which is where I worked, but it paints the patients, the students, and the facility in a terrible light. On the right is a celebratory photo from the 5th year medical students' graduation. So just remember that words, actions, and depictions are important. They can be uplifting and relationship building or harmful and denigrating. Next slide, please. And because I can't get enough of sharing stories, I have a case study or example. So early in my time in Uganda, this is a photo of the crowded emergency post-admission ward. I was about in my 2nd week, and as I was learning the new system, I arrived 10 minutes late to the emergency ward for post-admission rounds. I joined the group of students and residents there, but as I joined them, I noticed a patient in severe respiratory distress. That patient was gasping, he was diaphoretic, and his family was all around him. I quietly asked a Ugandan resident standing next to me about that patient, and he said the young man had presented overnight. His HIV test was negative, but the family had no financial means for medications, further testing, or imaging. And the hospital didn't have capacity to do any of that for him. The team had spoken to the ICU team, which is a paid private part of the hospital, and said that the ICU team was going to come and see him, but they often would take their own time to do that. So rounds carried on, but about 10 minutes later, another group of visitors showed up. So it was a fellow and 2 residents from the US from a different institution. They also joined rounds, but quickly noticed the same man. They go to his bedside and they started to examine him. They asked loudly in the crowded ward about the patient, and they say, "What's going on with him? Why aren't you rounding on this patient? This guy is going to die." The intern informs him that the ICU is coming to evaluate the patient and tells them the same story that they told me. The fellow then says, "When are they coming? He needs to be in the ICU now. Where is your sense of urgency?" As the visitors head into the ICU to find help, the Ugandan resident I had talked to earlier was standing next to me and looked at me and said, "When are people going to learn? It's not that we don't care about patients." So those visitors came back to the ward And they physically moved this man and his bed into the ICU. They took a Ugandan resident and a medical student with them. When they were done, the patient was intubated and stable in the ICU. The next day, I found the Ugandan team and I asked about the patient. He was stable in the ICU, and the Ugandan resident team had rounded on him in the afternoon as well as that morning. I actually asked about those visitors. I wondered if they had come to check on this man. And I was told that the previous day had been their last day, and this weekend they were going on a guerrilla trek, and then they were heading back to the US. Next slide.
So I think the weight of those stories are what Polka and I hear and see, and maybe he even had done ourselves. And so I want us to just kind of take a minute to think about some of the things you've heard other people say, or maybe you've said yourself. And because we don't want to leave you without answers, some of the things you might say instead. So consider, have you ever heard somebody or even yourself say, I'll just show up and see what I can do to help? So I certainly said that. This is one of a picture from a trip that I took to Honduras, which was amazing and excellently done in many ways. But I fully blame myself for not preparing as well as I should have. You can see me in the corner here, not speaking because I didn't know Spanish, and then an excellent physician and a student that did know Spanish actually caring for the patients at hand. So yes, I was there learning, and yes, that was great education for me. But it did come at an expense to my team and the patients. And I certainly did not offer as much as I had hoped because I didn't prepare really. So instead, you may say something like this: I'll come prepared with a skill that I can teach and that my host asked for help with. So here you can see me in Kenya. I'm teaching fourth and fifth and sixth year medical students, a couple of registrars and some clinical officers. I'm teaching something that I knew really well. It was the neuro exam, or how to do it. And I had definitely known it, and they asked. They said, "Can you please teach us this? We're going to be tested on it." And we need to know it. So that was a good moment. And I was glad somebody got it on film. And I think this kind of attitude goes a long way when you have really great skills to offer, which we guys all do. So it may not be medicine, but it might be dentistry, or it might be counseling, or it doesn't matter what it is. Coming prepared with a skill that can actually be useful for the situation and that the hosts are ready to use can be really meaningful. Next, I'm not trained to do this, but there's nobody else to do it, so it's okay. So there's a long history of just atrocious stories of students and faculty and everyone else doing things outside of their practice in situations that feel really desperate. I put a picture of a baby or a C-section being done, intrauterine surgery even, which are some of the more classic examples. There's whole websites of students bragging about surgeries they've done in third world contexts or in developing countries that they could never have done here because they're not trained to do it nor supervised. So I think you guys can see the problems of showing up to a country not trained and essentially practicing or just trialing things without even knowing what you're doing. We would never, ever allow that here. Now, and I realize there's a lot of caveats to this. There are often situations where there really is truly not anybody else to do the things that you're used to. So you need people with wisdom and oversight and lots more practice than you to be able to be there with you and say, I know you're used to doing X in this situation. We don't have that option, and we're certainly not trained to do it. So here's what we can do instead. Those are not things that come easily or naturally, even to really experienced clinicians. So instead, you may have an attitude of, my hosts will be managing this long after they leave, or long after I leave. They have a lot of tools and strengths. I'll work within my scope of practice and come beside my local hosts as much as I can. Sometimes just doing simple things like finding a chart or Helping track down a medication or finding a biopsy can be the most helpful thing that you can do while you're there instead of some heroic gesture. And I think our hosts are much more comfortable in general than we are with bad things happening to people when they don't have resources. But I think that the outcomes of us working outside our scope of practice are much, much more harmful than the bad things that can happen to patients almost all the time. So, have you ever heard somebody say, or have you said, they're poor, but they're so happy? So you see pictures like this, you hear those reflections of people coming back. And on the one hand, it can be very encouraging to hear that people can find joy and happiness without money. It's really good for us Americans to remember that in such a money-saturated culture. On the other hand, though, it can be just very denigrating. Like, of course they're happy. There are many happy things about life in all sorts of countries and societies. I put a picture of roses here because Kenya is one of the biggest exporters of roses to Europe. So you go to Kenya and I had roses on my table every single day. I can't afford that here. I can barely afford it any of the time. So maybe it would be more helpful to say they have so many strengths and assets. I'm not surprised that sometimes people are happy. The only other problem with that statement is this thing that one of our most famous novelists has reminded us, which is the danger of a single story. If you've never watched this TED Talk, I highly, highly recommend it. I think it should be just global citizenship training for everyone. In it, she talks about being a Nigerian woman coming to the United States and encountering all the prejudices and biases, some positive, some negative, that people had about her. She grew up in a pretty wealthy family in Nigeria and had experienced many things that Americans have experienced. But she got to school and was asked about got to college and asked about her tribal language and her tribal practices. And she said, well, I grew up listening to Madonna. How about you? So in it, she just talks about when we box people into having just one narrative, it makes things easier on our minds, but it reduces the truth about them to just one thing. So that's sort of what this narrative does. They're poor, but they're so happy. They probably are happy. They should be. But losing loved ones and having kids die of diarrhea before they're 5 years old is also just awfully, awfully tragic. And they feel those things too. So. I think social media and global health could be a whole nother talk on its own. But as a placeholder, you've heard and maybe even said, put things on social media with lots of black faces around one white face. And maybe you don't really think this, but at least it's gone through somebody's head. I'll post this on social media so people know I was really helping. Thankfully, this is a picture of my sister with people she knew really well. She would never dream of posting this on social media, so it's kind of ironic, but you can imagine that if this is put on social media, people are going to give it, 1.6 seconds to care about it. And what they're going to see is you in the middle of the picture as the hero with poor, needy people around you. And what kind of narrative does that set up? What kind of expectations do they have about the kids in this picture? Not to mention that these are kids in the picture. If a stranger came by and without my permission started taking pictures of my children, you better believe I will be stopping them. So there's just a lot of dynamics here that are not intended, or if they are not great. So I didn't actually write this post, but maybe I could have. Maybe you could say instead, my Facebook feed was quiet for a while because I was in Africa on a medical elective. I don't put pictures of my US patients on here, so I won't post any pictures of my African patients either, but please ask me about my trip. Considering donating to this development fund to support the amazing families that spend their time and energy teaching me for the past 2 months. And then you could include a link to any development fund particular to that area. Again, it's a little less sexy, it's a little less eye-catching, but it's a lot more honest and has a lot of integrity for the people that did spend considerable resources on you. Polka, to you.
So I think one thing you could say when you have a solution to problem is, I think it's clear what the best answer to this problem is. But I think maybe instead you should take time and realize your mindset and your problem solving may not always be what's right for the situation. So the picture on the left is a picture of a hand sanitizer battery operated unit that was installed by a well-meaning group that came to the hospital I worked at in Uganda. About 2 months after they left, the battery didn't work anymore. We tried to figure it out, couldn't figure out how to make it work. But it was also out of alcohol gel as well. And so in the hospital, the best thing to do was to, buy more soap so that you could wash your hands at the sink with the water. On the right side is actually a hand washing station outside one of the health center 3s where I used to go to in Uganda. And this fascinated me because I'd never seen it before. But basically it's a jug with water and soap mixture. And if you step on that little stick on the left, it'll pull down the string and the water will come out and you can wash your hands before you go inside the clinic. And so they had this out there for the patients and the clinicians, and it was a really useful solution that they could do on their own or refill. So I think it's often, you often go to places and you see problems and you think about what the solutions could be and you want to implement them because you know what's worked and what's worked for you. But what works for you may not always be the correct solution in the place you are. Next slide. And then I know we talked about costs, but think about, you're spending a lot of money to go on this trip, $3,000. And investing in yourself is definitely important, but you could also think about investing in others. And so could that money be more useful in a different way? And so shared with his permission, the picture on the right is a picture of Dr. Edwin Nuajira, who was one of my Ugandan residents, and now he's faculty in Mbarara. And Edwin was great, always on time, working hard, just like all his co-residents. But during his last year and a half of residency in Uganda, and residents in Uganda, and I believe residents in Kenya, pay tuition. They do not get paid. And that is another difference between that scenario and our scenario here in the United States. But he ran into some financial challenges and couldn't afford his tuition. So I was able to help with part of it. As faculty, Edwin now rounds twice a week on the main ward. He rounds on the TV ward once a week, and he teaches medical students and residents. So my investment in his education may be some of the best money I ever spent to help medical students in Uganda, patients in Uganda, and providing clinical care where I had worked. So we're trying to get official numbers for the AMPATH Eldoret site that we, a lot of us on this call know. Speaking to Kenyan students and registrars, it sounds like the training for a registrar, which would be equivalent to a resident here, is about $2,000 a year for tuition. A Kenyan medical student may be as high as $3,000 a year for probably a private or international student. And just thinking about something simpler, health insurance for a Kenyan family working in the informal sector. So someone who works on their own or selling something on the side of the street who doesn't have an employer can buy insurance for him or herself and their entire family for $60 for a whole year. And then AMPATH helps support students through the One Gaza scholarship at about 70 students, medical students a year. And so those are some really longer lasting potentially impacts that your money can make in that setting.
I think the next one is something that I hear students struggling with, and I so value the heart that is behind this. I hear them saying, I just can't go and learn. I need to do something to make this trip worthwhile. And that desire to help and to go and to be getting your hands dirty with paint or whatever is so real and tangible. And it takes a lot of patience to do any kind of medicine, but maybe even especially global medicine. I think probably a better thing would be to say, this trip is an investment in myself and my education. I'm here to learn, and I will do everything to make my host investment in me worthwhile. I'll use what I learned to help others in the right context later. This kind of just helps remind yourself that when you're there for a really short time, which 1 week or 2 weeks or even 2 months, sometimes even a year, you can barely scratch the surface of all you need to learn about a situation before you can help. And you're going to be draining resources at first before you can be helpful. So it's so much better to go and just say, I'm going to be here to learn, drain as little resources as I can, and I'm going to make the time and the energy that these people are putting into teaching me really worth it. And if I do, then later when I come back for a longer time or in the right context, I'll be even more helpful. This one is also super tempting to people old and new in the global health world. I'll take expired donated medications in my suitcase and pass them out at the clinic we set up. I've done this myself. I took bottles of Tylenol and other things in my suitcase and had the best intentions of distributing them and setting them up. Again, pharmaceuticals and full health electives could be a whole talk on its own, but some of the things that you guys alluded to earlier get at the problems of this. If I bring expired medications, some of the surface level problems are there. The medicines may not work. They really might be expired. Maybe even more deeper. What kind of system is it setting up where floods of expired or cheap medicines come in? What does that do to the supply chain for the local system? If they know people can get these free or cheap medicines, does that encourage local pharmacies or government agencies to actually create a system that works? Not really. But maybe even more significantly, what about the psychosocial implications of getting your meds from white foreigners and then not having medicines available from your local system? That breaks a lot of trust in the people that are there to help you and the systems that really should be working for you consistently full time. Not to mention, there are laws against it. So in many countries, there are laws against taking medications that you would not give to patients in your local context. So, and even if there's not a law, there's a moral code. You don't give things to people in developing countries that you wouldn't be okay giving to your mother. Instead, what can you do? So you can raise money and buy drugs there at a pharmacy you trust. Not all pharmacies are trustworthy in every country where you're going to go to. There are real counterfeit medications and lots of issues, but you can work with local colleagues to figure out pharmacies that you trust. You can, in Kenya and in AMPATH, they've set up something called the Revolving Fund Pharmacy for exactly this purpose. So it works alongside the Ministry of Health pharmacies. And Adrian or Sonek would be the best experts to tell us about it. But essentially, it's creating a set of funds that can be used to purchase safe, trustworthy medications to provide those for patients when the Ministry of Health pharmacies are not able to equip the patients with what they need. Supporting that revolving fund pharmacy, putting in medications of that, giving them expertise or time, any of that would be better than me going here and finding some CVS meds to hand out.
So I know we're getting kind of close to the end of the hour, and so I'll make these a little quicker so that we have time for questions. But this is a picture of the area behind the hospital in Edinburgh where I used to work. So medical waste is a huge problem. Well, a lot of the things you see in this picture are from local issues or like old bed frames. I think the 2 containers on that field are purported to contain expired meds. And there were definitely a couple of donated EKG machines, which didn't come with paper or had the wrong electricity. So if you're gonna bring something, make sure it can actually be used where you are. It's something that's wanted and something that can be maintained. Next slide.
I think I'll skip these and then we'll go through at the end if we need to. So what should our dear Kate, do about her global health elective? She so wants to be helpful and she's got some ideas. What should she actually do to be helpful? So first, this is the hard work and it is step 1 for a reason. You have to understand your own worldview, values, and biases. It's not pretty work, but you have to be able to think about, how do you see other people? How do you know right from wrong? Who gets a say in decisions? Why do people suffer? What's a good life? What are your values? What are your biases? This is meaningful pre-work before any global health trip, because you will find yourself asking yourself these questions if you're a thinking person while you're on a global health trip. Absolutely, you can go on a trip and not think about these things, but you will probably be hurting people in the process if you don't know the answers to some of these questions. Number 2, vet potential opportunities. So I really like some of these guidelines. These are guidelines from the WAIT group, and they put out just suggestions of how you would look at potential opportunities. And it includes things like emphasis on cross-cultural affective skills and cultural humility, bi-directional participatory relationships. So that means people coming from both sides of your partnership back and forth and having equal say at the table to decide what's done, who's going to do it, etc. It doesn't mean the host country gives all the land and resource and population and the sending country just sends money. That is not a bi-directional participatory relationship. Third, local capacity building. So instead of just showing up and doing all the work, are you teaching people while you're there how to do it for the long term? Are you helping build and support the system that's there? And that easily leads into number 4, the long-term sustainability. So if you are interested in capacity building, you're going to make a sustainable system because you're going to realize that when you're gone, somebody's got to do it. If you're serious about wanting to help, you're going to care about the outcomes for the local population. If you're looking at an organization, is the organization tracking those, or are they just looking to how satisfied you are at the trip? Once you look at enough websites for these trips, you'll figure out which ones are interested in the actual health of the population and which ones want you to be happy and come back again next year. You should be happy too. But. Step 3, ask the locals what they need. This can be a hard question if you've never been to a place, but you should find somebody that can ask, and you should listen and be prepared for when the answer isn't you. So Polka tells a great story about a group coming in and offering and actually insisting that the main need was a medical record. So they had plans to set up an electronic medical record, but they weren't going to be there very long. And the local system said, actually, what we really need is just paper. We have a record and we can figure out how to use it, but we just need paper to make it work. Can you bring some paper? So you can imagine that may be less attractive to people who are coming, but it's really what the answer is. Polka, do you want to talk about this slide?
Sure. So I think Jenny and I are a little bit in a difficult spot because we're not host country, people welcoming you when you arrive in country. We're a little bit, we don't understand all the details. So for a local perspective, one of the heads of Department of Internal Medicine where I worked gave this presentation called The Helpful Visitor. And I put her main points up on the slide, but just to briefly highlight some things, our helpful visitors plan ahead. They get licenses and fill out university paperwork. They're committed, they help build capacity and have mutual trust and respect with their host partners. If projects are being done, they include local collaborators in design, planning, publication, and presentation. Burdensome visitors who they've had before can be disrespectful. They use anger, they berate learners rather than demonstrate. They think poorly of the local students, residents, and faculty, and they take pictures without permission. They don't adhere to the dress code or local reporting levels. Next slide.
So just a couple more steps, and Polka alluded to this, follow legal and cultural rules. So getting appropriate licensure. So when I go to Kenya, I forgot to take a picture of it, but I get a medical license. And at least 6 months later, I might actually get a copy of it, but I have one. I'm credited to work while I'm there. Get appropriate health screenings and measures. In this day and age, that's going to be COVID testing and things like that. And just remembering that you're acting as an ambassador of your country and your institution, even if you didn't sign up for that. So if you are coming from America, you will represent all Americans to these to your hosts, whether you like it or not. So that may come with things that you don't like, but be prepared to deal with that. Step 5, prepare. So learn the language and culture. Like this picture shows over here, my colleague hard at work learning Spanish. You can spend time really thinking and learning about the culture and the language before you go. You should practice talking to people who are different than you. So if you find yourself mystified by, name a group, Muslims, Christians, anybody, go find somebody that's identity you don't know much about and learn about what they think. Just ask them. Better yet, try to solve something together, because that's what you're going to be doing in a global health context. So better practice here before you go. Learn about yourself to increase your cultural humility. And be prepared to be stretched. Have your coping mechanisms handy. It's one reason why AMPATH invites significant others to go with students when they go, because they know that those coping mechanisms are really helpful to help students adapt and process these really intense new experiences. Step 6, learning about local realities. So you may not be able to learn all about these before you go, but these are things like, in many parts of the world, you can't get all of the proper inhalers that you would need for your asthma. So you might end up making them out of an old water bottle. And you know what? This is actually a great mechanism for getting your inhaled medicines into you put the medicine on one end and then it comes out the other. So this is the reality for the local situation. I also just kind of love/hate this series of pictures. So on the left, you can see there's a sign on my pop machine at my husband's workplace, apologizing to all the physicians in the physician's lounge for being out of carbon dioxide for their soda. And on the right is a text sent by one of my students on one of my days when I was in Kenya. He and I knew that the oxygen supply that day was pretty short. And he texted me at the end of the day saying, hey, we ran out of oxygen. And the implications behind that were that we knew that there was going to be at least 2 or 3 patients that were probably not going to make it through the night because they were just right on the edge. And indeed, they did not. So if you come to these places and you're startled to find that things are different than where you're from, you're going to be pretty struck. Step 7, learning from the experts. I think this is one of our last ones.
Yeah, so I think in Senegal, they're doing great with COVID. We almost made it through a presentation without talking about COVID, but they get their tests back in 24 hours. They have hotels for quarantine. I think we could learn a lot from them. And on the left side, Katrin Kelly is in the picture, but she's learning about the work a community health worker in Uganda does, because there are experts wherever you go, and you should take time to learn from them. In other countries, public health infrastructure and healthcare is set up much differently than ours. And so learn about the systems, learn from people who practice this every day. The next slide.
Be prepared to find things that you want to bring back here, because lots of people are doing things better than in the US.
Yeah.
So, and to that end,
I think for step 8, celebrate doing what you can with what you have where you are. So a little thing you can do if you go to a malaria endemic country, you can't donate blood when you get back. So you can donate blood while you're there. So on the left is like 7 or 8 units of blood from a blood drive we did with visitors in Uganda. So lots of US blood going to help Ugandan patients. On the right is a tutorial session I gave to a small group of students who requested extra time, and they wanted to take a picture at the end, and they wrote me a really sweet thank you note. So little things really help.
Step 9, pack well. So humility, humility, humility. I could probably have written it 10 more times. If you show up at a global health elective expecting to have answers and all the right ideas, you will be less effective at treating the people you want. So just be humble. Figure out what's working well though. To that end, being curious will just help. Instead of saying, why aren't you doing it this way? Have a true attitude. Like, what are the things that make you know that that's the right answer in this situation? Teach me. I'm new at this. Patience, flexibility, ability to think before you talk is always a good policy. Enthusiasm for questioning your assumptions. So you're going to have to go in and say, wow, this seems really obvious that this is the best plan, but why do I think that? And who else can help me answer this question? Okay, last line. So pearls, think carefully about how and when you go. Sometimes consider staying at home and donating money. Sometimes you should go, but pack humility, curiosity, patience. You need vacations, rest, and adventure. Just don't do them at the expense of anybody else. You are worth investing in. Going to just learn can be really valuable. Do no harm. In general, don't do projects or seek publications on short-term trips. And work with and uplift your local colleagues. Work to minimize how much you remove and use their resources.
I'm not sure, hopefully we have time for a quick last story, which is shared with permission about the woman in this picture. So this is a fantastic picture of the male Ugandan residents all wearing bow ties because they learned MGH in Boston. The residents all wear bow ties on certain days. So with them is Dr. Rose Muhindo, who's the head of Department of Medicine where I worked. One day I was eating lunch with her and I asked her, because she has some extra training in nephrology, so she acts as the acting nephrologist there. And I asked her why she chose to do extra study in the field of nephrology. And she told me when she was a medical student at MUST, the same university where she works now, she remembers a woman visitor from Canada who visited for a few weeks. That woman was a nephrologist, and she remembers that that visitor treated patients with kindness and expertise. She was so knowledgeable about the kidney and its diseases, and she spent extra time teaching the medical students, which Dr. Rose was one of, about the kidney and about a lot of nephrology. It really inspired her. So because of that short trip, Dr. Rose sought additional training in nephrology, and now patients, students, and faculty in that city get to benefit from that. So to me, that's a story that demonstrates how a short trip, when done well, can make an impact. And that wasn't a lot of extra work or problem solving or bringing things. And so I think there can be benefits to short trips, but just remember there can be a lot of harms too. I think that's
it.
What we got.
We welcome comments, feedback. There's also going to be a reading list posted in the chat here for a minute if you'd like to read more about colonization and short-term trips.
Jenny, can I say something?
Please. So
thank you to you and to Palka. You've said so many things, so many threads to pull on. I just very quickly say, Palka made a comment about well-meaning, and that's another whole discussion about well-meaning. I just want to go right back to the beginning, because I've had the privilege of working in very remote communities in several continents. And that is, the first thing a phrase I like to use is the Heisenberg principle in global healthcare, meaning that when you walk into a village or a town, you change it by just walking in. From the US, from Europe, that's where I started, from in England, but from here. And that's something we first of all have to understand. And the second part is that those people may not see disease and life the same way we do. You know, and that sounds very strange sometimes when I talk to students that way, but they may not see disease and our role in this life, in this planet, in the same way. I'm not talking about something theological or religious here, just about how human existence is. And I think those things have to be understood in some environments. I mean, AMPATH obviously is very well organized and very, very long-term established, as you said. So I think there are principles there that need to be addressed right at the beginning.
Absolutely. It's a great point. Schrodinger's cat, if you will. It can't be.
Yes, exactly.
Yeah. Taking me back to my chemistry days. I love it.
Any other comments or questions?
Hey guys, this is Sonak. One quick comment and an observation of even the term global health is something that I'm trying to use less. And the reason for it, you know, and I challenge everybody to consider this and think about it, is I struggle with defining the word. And the reason for that is that it's a term that is basically further establishing this notion that the US and high income countries are at the center of the world and everything outside of that is global. And the example that I challenge myself with is, you know, so I've worked in Kenya for a long time. Are all the Kenyan pharmacists I work with global health pharmacists? Or, you know, the Kenyan physicians, are they global health physicians? And by and large, my answer is no. And so it just doesn't make logical sense to even use the term global health, because it requires us to basically acknowledge that the US and high income countries are the center of the world, and then everything outside of that is global. And likewise, if I were to say that I worked in the UK for all these years, would you consider me a global health practitioner? Most people would probably say like, I'm not sure. And so to me, it's more about addressing inequities, which you guys talked about towards the end, and the last commenter just commented on. But to me, I'm trying to train myself to stop using this term of global health, because it doesn't mean a lot to other people who might not be from the US or a high income country.
So how do you describe your work instead?
I work on health equity.
Health equity.
I want to work wherever there are issues where populations are underserved, and there could be efforts that could improve the situation. And the reason why I think that's important is because of one of the other comments about disparities in the US. How can we reconcile going to other countries to contribute to their healthcare systems when it seems like there's so much disparity in ours? And to me, the response is, yeah, agreed. We should definitely address that, and we should all be practitioners of health equity. And even, imagine this for a second. We have Danes and Canadians on this thread. Imagine if they came to America to do what we tried to do in Kenya. I would be all for it personally, because their health care system outcomes are much better than ours. But you know just as well as I do that most of the providers in the US would have none of that. And so it also forces us to take a mirror to ourselves. Are we actually willing to try to improve our own practice as much as we expect our Kenyan collaborators to?
Right.
Yeah.
Raj Vedantan here. Can people hear me?
Mm-hmm.
Yeah, a wonderful presentation. Thank you so much. And Sonak, a very nice comment as well. I think that a very important point also that I think you all raised, which I think is very important for all of us, both long-termers and short-termers involved with AMPATH, to recognize is that none of us are innocent. All of our experiences, quote unquote, in global health, even in the context of AMPATH, which I generally feel is a wonderful program, are also guilty of many of the things that you have described today. And I think just very important for us to, I think all of us individually and as a community, to reflect on that. But I also don't think that it's necessarily possible, even quote unquote, to be perfect. I think, Jenny, you had made the point that it is a human endeavor. Humans are imperfect, but the idea is that we are sort of working towards getting better, both individually and as a community, both locally and globally. So I think that's a very important point. Also, I think, just as Sonak was saying, there are many similarities to what you were describing, especially from the context of the trainee, or let's say the medical student or the trainee. That very similar situations to at least the medical training that happens in this country. Many of us who went through medical school, quote unquote, practiced and learned on poor people in public hospitals. And that's not necessarily that fair to those patients either. And so I think there are many similarities to at least the medical training. I can't comment on necessarily other health professionals that many of us have gone through even here. And so I think very important for us to sort of think about those parallels to our experiences, closer to home as well. Anyway, very, very, very nice. Thank you. And I think just important for us to continue to reflect on these issues as we continue to engage in communities, whether they be in Kenya, New York, Indiana, etc.
Absolutely. Thank you. Great comments.
Well, thank you very much, Jenny and Polka, for that really sort of challenging presentation, and certainly makes us all think. I think, as Raj said, I think all of us are sort of guilty in some ways of doing this, but I think it's also important to recognize that, the AMPATH program does go sort of a long way to, put things in place that are bring out the best of these experiences, not the worst. So, even our medical students and residents, while they do an 8-week rotation and learn a lot and adapt to the culture, they practice in the context of an institutional relationship and counterparts, and a long-term partnership that's really committed to leading with care. And I think, those, and bilateral exchange actually, which is an important piece too. I think that each institution, supporting Kenyan trainees to have that same experience, which, I think is really an important part of the philosophy. So again, thanks for making us think about it. And I think there's a lot in this time of COVID, a lot of more discussion and challenge about decolonization of global health and what do we mean by that. And I heard someone refer today to three things: cost, carbon, time. Those are the things we should be thinking about as we think about global health. And we're no longer traveling as much, right? But what about the cost of travel? What about the time we spend doing it? Sometimes those things are better spent in other ways, right? So, which is one of the points that Paul made. So, anyway, thanks so much again, and thanks all of you for joining us tonight. As you all know, this work relies on support of people like you and donations to the AMPATH training and education programs. Paul mentioned the Mangaza scholarships for Moi medical students. And we also have a Global Health Education Fund that was recently created honoring Bob and Leanne Eintertz, that's supporting bilateral exchange. So there are some opportunities to support kind of sustainable exchange and global health experiences. So feel free to reach out if you're interested in learning more about those. Our next month's October chat will be led by Sonak Pastakia. The title of his talk is Applying the AMPATH Approach to the Street, the story of the Tumaini Innovation Center. So there's a little teaser for next month. And if you've never heard Sonak speak, he is a very dynamic powerhouse speaker. So definitely plan to tune in for that one.